Good evening, ladies and gentlemen, and welcome to tonight's Wound Care Today Facebook Live. It's glorious outside here, so it's glorious with you. Thank you for joining us and sacrificing the sun and the gin and tonic to join this education. We're well aware how busy you are, so it means a great deal to me and the speakers that you've joined us. Tonight's event is called Treatment of Wounds in Challenging Areas, Hidradenitis Suppurativa, which I'll be shortening to HS for the rest of tonight's event. And our amazing speakers who are legends of wound care, I'm going to say wound care royalty, and have been supportive of Facebook Live since the very beginning. In fact, Joy was our first ever presenter, Joy Tickle and Alison Schofield. Good evening, both.
Hi, Ed. Hi, everyone.
Hello, everybody. Thanks, Ed.
As you can see, guys, they are presenting from home tonight. So if we have any technology problems, please bear with us and we'll get them sorted as soon as possible. The link for the certificate of attendance will be made available towards the end of tonight's event. Please download that. That counts towards your revalidation. And also all the slides tonight are available for download on our website, which is woundcare-today.com. So you don't need to take notes. You can download the slides afterwards. As Joy and Ali will agree, the more involved you are, the better it is for the event. So please make comments, let us know where you're watching from, but also please ask any relevant questions and we'll endeavour to answer as many as possible towards the end of tonight's event. I'm really excited about tonight's event and the education around HS. So without further ado, it gives me great pleasure to introduce our first speaker tonight. Over to you, Ali.
Thank you, Ed, and how lovely to be back here presenting Facebook Live to you all and to be with Joy Tickle, who is a good friend and just such an amazing TBN. So as Ed had said, we are looking at treating wounds in challenging areas and a big focus on hidradenitis suppurativa, which I've been involved with over the past 2 years, raising awareness, education and working alongside some amazing clinicians in dermatology. So the learning outcomes that you will get through this session this evening will be to highlight what a devastating condition HS is, look at the clinical features that will aid better recognition of it, understand the impact on a patient's quality of life, explore the challenges of treating these areas, discuss wound care treatment options, what is available, any practical advice for successful wound management, and also to help raise awareness to improve that all-important diagnosis. It's important with HS we get an earlier diagnosis so treatments work better. So we're not here this evening to talk about the biologic treatment or the antibiotic treatment or the surgical treatments that are available for HS, and that's done in the dermatology setting. And just a shout out to the dermatology nurses, I know some of them were joining us tonight. So what is HS? And some of you may be aware of the condition, some of you may have treated patients with it, some of you may have it within your families, and some of you may be thinking, well, I've joined tonight because I'm not really sure what it is and I want to find out. Well, it is a chronic inflammatory scarring follicular disorder that manifests with painful nodules, abscesses and draining tunnels. And it creates these malodorous leaking lesions that come up and down in flare cycles. It's not an infective disorder and it's not a condition of the sweat glands as it used to thought to have been many years ago. It's actually a disorder of the hair follicle, the root, and it affects the sebaceous glands. So it has these profound physical and psychological impacts, which we will explore and go into. We've got a lot of data around that's been collected. And also it's more than any other skin disease. I'm sure we've all heard of psoriasis. HS is about the same prevalence, but we don't really hear about it regularly. And it has more of an impact on the quality of life than any other skin condition does. So you can see here on the screen now just a few images that have been shared with us of different stages and different areas where HS occurs. So I just want you to think about this for a moment. Think about who gets HS and how it affects them. So it starts to occur after the onset of puberty. So think of when, say, as a female, when you started puberty, and a lot of patients are telling us this is around the age of 10, 11, 12 years old, young teenagers on average. The diagnosis for HS is around 22 years. So if they're starting with onset of boils and lesions around, those young teenage years and preteen years, that's a long time to the diagnosis. So patients tell us their stories about these lesions and abscesses that are starting then, and then they've hidden them away for years. They haven't told anybody, and when they eventually do, and they get to go to a GP appointment, they might be told that it's a hygiene issue. They've got to lose weight. Some people even told me that they were told, oh, well, it's linked to a deodorant that you're using. These are all absolute myths, and can we just stop that right now? So as I said, HS is diagnosed. It depends on the person being referred into dermatology largely to get, but it's often when it's in the later stages of the condition. And I've had the privilege to work alongside dermatology and nurses and consultants in the HS clinic and seen patients there. And patients are really receiving an inequality of wound care in community and primary care when they go back out from the acute clinics. So we have to provide integrated working. I just want to say this right at the start because it is so important. We have to bring dermatology, tissue viability, wound care all together because it's everybody's responsibility, because these people deserve a lot better. And especially when we think of the suicide rates in people with HS are double that of the normal population. So where does it occur? So that we can see on the diagrams, these are typical areas where we will see HS occurring. So that can be in the armpits, in the groin, around the buttocks, and on and around the breast. And there are less common areas as well. So peristomal areas, the areola of the breast, the submammary folds, even on the head, on the scalp, and I've seen it on the back of the thighs as well. So think about if you are a person in your practice, say if you're a practice nurse and you're carrying out smears or breast examinations, and for everybody else, we do skin assessments, don't we? Pressure ulcers, primarily we do those risk assessments. Look out for the issues we're going to be talking about. Look out for scarring in these areas. But let's be having better conversations with people about their skin. It's the largest organ in the body. We have the ASKING acronym that we use in pressure ulcer assessment. Well, that will fit in any area of skin assessment. So we need to be talking about the skin more. So what are the wound care challenges? Well, think about HS, but also think about those other areas where it's challenging to apply dressings and to dress wounds in. And, you can put it in the chat and let us know what your thoughts are. So not all dressings are suitable for HS, because if you think of the areas where it's occurring, like the armpit, we've got images on the screen there. These are concave surfaces, aren't they? So they're not flat, like applying a dressing on a limb for, say, a venous leg ulcer. And even the gentle bordered dressings in HS, we might need multiple of them for, these wound areas that there's multiple areas that are leaking a lot of fluid. I was in HS clinic a couple of weeks ago. We had a gentleman came in. He was in his 40s and he'd lived with HS from, a young age. And he was a driving instructor and he was sat down long hours driving. And he came, we sent him out of the clinic that day, so we had to dress the wounds. And he had about 7 different dressings in the areas around his buttocks and his groin. And he told me that he had a bath in the morning and a shower in the evening because it eased his symptoms and he felt that he needed that because of all the leakage. So those dressings aren't going to stay in place, are they, all that time, as gentle as they are in the skin. So that was a lot of time to him. And we think about then those costs to the NHS, and we're talking about net zero and sustainability. It just doesn't add up with that, does it? And also we've got there on screen, you'll see it says genital edema. Now this is a secondary issue from HS and also after surgeries. The areas where these are occurring is where we have our lymph nodes. So we see many men coming into the clinic with early stages of lymphedema, and I've seen them with very late stages where it's been totally unmanaged, it's not been picked up, it's not been assessed for, there's been no self-care advice management for it, and then they're having to go for full-on plastic surgery to rectify it. Wound care challenges also are around restricted movement, so bulky dressings, dressings that are absorbed, but then they're swelling up. How do we keep them in place? And people are making their own makeshift kind of garments and wrapping bandages round. And the dressings don't always stay there. And a lady told me of when she was, a young teenage girl of 13, 14 and went to a party. She had a lesions in her groin. The dressing dropped out in the middle of the party, and the shame and embarrassment that she felt with that. These patients are very young. They're going to school, university, into the workplace, and this is affecting so much of their lives. And what do they use when we ask the people with HS and they're not getting the treatment choices that they should be doing on prescription? They're saying kitchen roll, that's the biggest one people use, continence pads, sanitary pads. Let's think about the dignity. Let's think about equality of care. The NHS long-term plan is all about equality of care in the integrated care systems. So let's give it to the patients with HS. So what's the most appropriate type of dressing? Well, I don't think it's this one, is it? And I'm sure you'd agree. These are kind of the typical island adhesive type dressings, or we've got gauze and tape. So we can see the amount of leakage that is there. And also we're going to get, the problems of skin stripping, which is, medical adhesive injury, but when we get the epidermal removal of something that is just far too sticky. People are changing the dressings 3, 4, 5 times a day. So imagine how that would impact on your daily life having to do it. We do have solutions, and Joy's going to talk about that a bit further on in the session. We also have to think about, antimicrobial stewardship, because antibiotics is part of the treatment pathway often, but how, can we improve that by improving our wound care? And, the type of dressings we're using, do we need to be using antimicrobials or not? Because we've got that stewardship and antimicrobial resistance that's going on. But what we have got is some evidence emerging of when we're using the appropriate dressings and we are managing the exudate, that we are then managing harmful proteases and all those other cellular elements that go on and the things within exudate. And if we control and manage that, then we are starting to see signs of wound healing and the flares are lessening. And also that will control odour management, because odour is an ongoing issue as well. So the pathophysiology of HS and what's happening there in the skin, underneath the epidermis and in the dermis. So we've got the follicle inflammation with the lymphocyte increase. They have a hyperkeratinization of follicular epithelium, and that forms this keratin plug. So we have an occlusion, a dilation of the hair follicle root, and then that ruptures and it releases the debris of pus and blood, and that comes up through the dermis and out through the epidermis. But also it forms tunnels and it tracks, and so we've got several areas erupting in one area or more than one anatomical area. The analogy of it, I always think, is like a volcano of, it's building underneath the surface and then it erupts through, and it can go on for days, weeks, months, longer than that. It's individual to every person. We don't know the cause of HS. We don't know exact causes. There's no specific testing for it, but we know there are risk factors and comorbidities associated. So genetically, it tends to run in families. I know when I was presenting this on the 2 years at JCN conferences, a lot of people who would come up afterwards would talk about, the recurrence in families. Also, people with immune disorders or a poor immune response, immune issues. Hormones is an interesting thing, and definitely we can see that with females, where onset of puberty, as I said, but then through when somebody is menstruating, the flares become worse, and then it can die off a bit during pregnancy, and then during the age of sort of 50 plus, when we're going through the menopause, it tends to decline as well. Now, obesity is on there, and I, this isn't a cause. And a lot of patients I've spoken to say, well, it's kind of a vicious cycle, because when they have the flares, they kind of withdraw and stay at home, and then they comfort eat, so they put on weight. And not everybody I know with HS is overweight, not by any means, but the mechanical friction of having the skin bulge, it's these moist areas will exacerbate things. Smoking, there's a high percentage of people who are smokers or former smokers, and again, that's not to say everybody is, but when you look at wound healing and smoking, the alkaloids in cigarettes promote Staphylococcus aureus proliferation and the change in the microbiome of the skin, so that might have some influence. And also nicotine secretion in sweat can lead to epidermal hyperplasia, so that causes a follicular occlusion and a decrease in the macrophage activity. The macrophages are like the Pac-Men of the wound care world. They come into play in the inflammatory wound healing process and try to clean up the wound. So they're quite interesting points. And we've got associated comorbidities as well. So again, the cause we don't know, and we can't do blood tests. People often say to me, well, can we do a swab? If we do swab the areas with HS, they often are non-pathogenic because it's not an infective disorder, but that doesn't mean that we can't go on to have a secondary infection, as with any break to the skin integrity, that does happen. And one study I sought out said that the microbiome in the general skin in the population of people with HS was higher than not. So we've got metabolic issues on there. So metabolic syndrome we associate, don't we, with inflammation. We've got diabetes, which obviously can have lots of issues associated with it. Cardiovascular, again, double the comorbidities of our cardiovascular disease in people with HS. So that is to be assessed for when somebody has the diagnosis and at their appointments. The inflammatory bowel disorders like Crohn's, ulcerative colitis. Polycystic ovary syndrome is one, and the thyroid dysfunction, and then the rheumatological type problems, and systemic lupus again has its own kind of skin issues and is linked to the immune system. And then we've got some malignancies there as well. So what's the prevalence of HS? Well, we don't know the exact figures, but what we do know from the data that's is it's about 1% in Europe, but it's probably likely to be a lot higher than that. If you think what I was saying about the time to diagnosis being delayed, and actually it's about 7 to 10 years before somebody gets diagnosed with HS. Can you imagine that? Somebody with a leg ulcer or a pressure ulcer, and it taking that long to receive the diagnosis. It's unbelievable. So, but 1% is not a small number. It wasn't long ago we were talking about 1.5% of people in the UK with venous leg ulcers. So, it's more than what we thought. And it can be confused with other diseases like pyonidal disease, subcutaneous Crohn's, acute abscesses, and acne as well. And if you're like me and have worked predominantly in community services for your nursing and healthcare career, you will probably have seen a lot of, I was in district nursing for a long time, and, we used to see a lot of patients with pyonidal disease and, recurring kind of surgeries. And I start to think now, did some of those have, did they have HS? And, when we're talking about the kind of the associations, there's some facts around people with Down syndrome and people of a higher prevalence, and also people with of African and South Asian descent. And again, we just don't know why this is. So on this image, you can see this is a recent paper in 2020 which is a formed consensus on the lesions that are formed. This is what we see with HS. So it's helpful in forming a diagnosis and treatment, so we can look out for these in practice. So we've got the papules, like the solid lesion. We've got superficial pustules, nodules. We've got plaques, ulceration. Some of the ulceration you could even get, confused with pressure ulcers, I guess, because of how the spherical shape. Abscesses that are leaking, the tunneling and tracking, and the comedones. Now, comedones to you and I are black and white heads, and you think, well, every teenager's got almost got black and white heads, but when you see them in the typical areas where we're talking about of where people have HS, and you become familiar with that, then you can see that. So we do have classification systems, and I guess this is maybe the main one that's used, which is the Hurley stage. But unfortunately, people are not presenting into the right services or until they're in the later stages, and patients present a sort of a certain point in time of when they've got problems and issues, and it might be that when they haven't got the flare, then they feel better to be able to go to the GP and they're just describing it, but the GPs then don't have that visual assessment of exactly what's going on. So we've had this shared with us, the diary of a HS flare. So just to kind of explain, what goes on kind of with a period of about a week. So a person would describe that they feel fatigued and malaise. The area around it feels sore, warm, tender, and by then that swelling's getting worse and it's more hot to touch. And we associate that, don't we, with inflammation and erythema. Day 2, it's become more inflamed and painful, and then the mobility's been affected. The skin is stretched tight and taut, and this goes on for several days. And then after about a week, the opening's now appeared and the lesion will drain. There are sinus tracts beneath the skin, and you can actually feel that occurring. And this is going to continuously trickle and drain. And then the aftermath of the HS flares is that the skin, when it's healing, is left pitted and scarred and disfigured, and it restricts a person's movement. I remember in the clinic, a lady came in and her husband was sat outside with her toddler, and she had the areas under her arms really affected, and they were very scarred. And she just said, I can't lift my arm. She couldn't lift. She said, I can't lift my baby. She couldn't move her arm so much. And another lady who was in her 40s, she had it around sort of a buttock area, and so sitting was very uncomfortable. She said, I don't want my partner to come near me. She didn't want intimacy. And she said, I actually feel she felt very suicidal. She admitted that to us. So, and it affects, obviously clothing choices in summer, swimming, sports, people wearing baggy clothes, hiding away, withdrawing, and social isolation. So we've just got a video for you that will play, and what this video is of somebody with a HS lesion, and so they're just pressing on it, and then you can see how that leakage is coming. You can see it's sort of, you see it there draining, and it will continuously leak like that for a long time, and it can be thin fluid. It might be thicker exudate. But yeah, you can imagine then how that's leaking through a person's clothing. So I just want to tell you about a story. As you're looking at the images there on where HS occurs in typical anatomical areas, and how that impactful that is. And it's just that I'll just quickly tell you this before I sort of hand over to Joy. But this is a story of a lady called Amy, who I have the privilege to know, and she's had her story published in the British Journal of Dermatological Nurses journal. It was done in May of this year, and she says, I felt as though there was something wrong with me. I felt alone, scared of being bullied. At 13, it was a lot to deal with, and I'd simply had enough. Boils were more frequent under the breast and in the groin. She tried to self-lance to release the pain. The GP said it was due to weight, hygiene, and would disappear with age. She said it held me back mentally and stopped me forming relationships in her late teens and even until now, and she's just turned 30. It dictates what I do, what I wear, how I feel, and how I look. It's a disability to me, and I've received counselling. And Amy did get a diagnosis and treatment plan. That was in 2019. She was 26 years old, 14 years after she first went to the GP. And she's now got specialist support in place that I can, thankfully tell you. So now we have the atypical images of where HS occurs. So that can be on the face, on the chin, behind the ears, on the toes, breast, stomach, chest, back, hands, head. So, other multiple areas that come up. So look out for all these. Now I'm going to hand over to Joy. And Joy, I'm sure, we're all thinking as well, we always talk about other areas where we can have challenging wounds to treat. And you can tell us about, what the kind of the treatments are available are for us. I'll hand over to you.
Oh, thank you, Alison. Yeah, I mean, it's a subject that I know you and I feel very passionate about. So yeah, when I've nursed quite a few patients now with HS of all age ranges. But when we were looking at the challenges, and there's a lot of the challenges are around the wound management, if I'm being honest. But it made me think about other wounds. Every day in practice, like yourself, I've been a community nurse, I've acute nurse, worked in acute, and there are some very challenging areas of challenging wounds, but it's normally because of the area that they're in. And you can see on the screen some examples of that. Malignant fungating wounds. How many of you can say that that's a challenge in itself, isn't it? From a point of view location, from a point of view of the wound signs and symptoms, such as increased exudate. Sometimes they're in visible, if we talk about facial tumours. And we have to be quite adaptable with how we use our dressing, should I say. And I think, Alison, you've touched on that in the sense of we sandwich dressings, we cut, we adapt, and we try and make dressings fit, but they don't always work, do they? Although there's some good dressings out there, they don't fit. Post-surgical breast wounds, patients who've had mastectomies, that can be a challenge in itself due to the body shape or the contouring and the dressing location. We've talked about dehiscence, surgical wounds to the groins, those areas where there's increased body air, there may be increased sweat, increased heat. So although there may be an effect, a good evidence-based dressing, it just may not stay in place, and it can often leak and not manage the signs and symptoms of some of these difficult wounds. And you've touched on the pilonidal sinus wounds, Crohn's subcutaneous lesions there. And again, it's all to do with, not just the location, but the body hair, the sweat, and the contouring, but also skin folds, where there are skin folds involved. So that often leads to many challenges. Now, I know, as all of you in clinical practice, a lot of the challenges when it comes to hard to heal, hard to dress wounds is around your time. And I know clinically we're all saying, I bet you can all picture a patient you may have seen today that you may see tomorrow. And managing that patient's wound is time consuming. And, there's various current studies that show that over 50% of nurses' time is spent on dressing change, on supporting that. I would say that's probably higher as well. And I'm sure some of the community staff out there are probably nodding at this point. And 2 to 3 times on average for a chronic difficult location wound to dress, 2 to 3 times at least a week. Some of these patients with HS, as you've heard Alison say, 2 to 3 times a day, if not more, okay? And it has been found that actually, if the dressing solution could fit those challenging areas, up to half of those dressings may not be necessary. So you can imagine the impact there for the patient on their quality of life and reducing their pain. And 77% of healthcare professionals who were asked around, you know, this area of chronic wounds and management of hard to heal or difficult wounds, 77% that if we could involve the patient more in supported healthcare, it would help then to improve the patient's quality of life. And again, I'm not saying anything that you haven't already heard before or that you're already encouraging in your own workplace. To me, I get very passionate about the patient's quality of life. What does it mean to them? We've talked about, you know, for us as clinicians, Alison's mentioned the cost. You know, I saw a patient recently with a HS wound that had 2 different size foam dressings applied, 2 different antimicrobial dressings, was having it reapplied at least twice a day because, not because the dressings weren't suitable for the signs and symptoms, it just did not stay in place. It was causing significant problems for the patient. And you can see on the screen here, 78% of patients who have a HS wound reported significant impact, negative impact, should I say, on their quality of life. 78% of all of those patients, they talked about staining, leaking, increased dressing changes, increased exudate, all those factors that can then lead to maceration and peri-wound skin excoriation. Now, I want to take you back a little step here and just imagine now this is you. These patients frequently at work have to take changes of clothes, have to take multiple dressings, have to visit the bathroom frequently to change the dressings. These dressings may be malodorous, so they often get embarrassed. They take deodorants with them and air fresheners, all sorts of things to hide their embarrassment and of course, try and not discuss it with their colleagues, but sometimes they have to. Massive impact. Can you imagine if that was your son? We've just talked about adolescence with puberty, your daughter. Can you imagine at school? I have patients who go to university and this is significantly impacting their quality of life, and I'll talk a little bit more in detail with that. So often that leaking and that frequent dressing changing, of course, is going to lead to increased pain. 98% of patients with HS report significant pain during dressing change, but real extreme pain, at least just short of 50% of those patients, but ongoing pain as well. This is not just on dressing change. This is hot, burning. They talk about throbbing or even the skin feeling quite stretched. And as we can see, 93% have experience of the dressings falling off. Alison's already mentioned the embarrassment and loss of dignity for that lady of the dressing that fell off when she was at a social event. And importantly as well, you know, when we look at the areas we're going to be applying dressings, quite a high percentage, 85% of the patients have reported adhesive skin damage. You know, even with, you know, what we would call, you know, silicone-based or safe, gentle adhesive dressings, 85% of some of these patients still report adhesive skin damage. Excuse me, you can tell it's live. And then that's going to cause further skin damage, further pain, or even extend the wound size itself. So again, significant factors. So I'm talking a lot about quality of life, and I'm going to talk about the mental health impact of HS. Now, I've only got 20 minutes, and I would implore, just really ask you all to read further about this. And we've got some really good information at the end of the presentation, because this is massive. Alison's already mentioned about the suicidal, you know, tendencies twice as high in the patients with HS. That, you know, patients are living with this chronic debilitating condition day in, day out, and it's going to have a massive impact on their mental health. We talked about loss of work, attending clinic appointments, or just the shame and embarrassment that some patients refuse to work. You know, when they actually could work, they become not just socially isolated, they hide away in their homes. They become isolated from their own partners, their own family members. You know, frequently, you know, embarrassment around their body image, their self-esteem, not sleeping with their partners anymore, not sharing the same room, and even to the point that actually shy away from even wanting to establish a relationship. And again, Think of the age group we're talking about here. You know, think also about, you know, the younger generation where relationships and all of these factors are so important to them. They in themselves lead them to have lots of anxiety, let alone having a condition like HS. And then that can lead to higher mental health illness and higher substance abuse and other factors. And I want to just share with you what one patient said after receiving some support. It's not one of my patients, it's a lot of the reading I've done around. It's a true patient. And she said that if she had to pick a treatment that she would keep when managing HS, she said it would be the mental health support. She said it was worth more than anything else she'd received in the whole 10 years of having HS, and it made the biggest difference to her quality of life. And I think that just speaks volumes, doesn't it? You know, the impact of that mental health support. And there's various studies that have looked at that quality of life aspect, that looks at the patients' lives living with HS. There's lots of studies that have asked participants living with HS to actually score and comment regarding their quality of life. And there's a Dermatology Life Quality Index scoring system. I'm going to refer back to that in a minute. And that's been used in lots of studies across the healthcare arena of managing patients with HS. And what they look at is the impact of HS on 5 different groups. So psychological factors, economical factors, pain, living with the dressing, social impact or social isolation impact. And every patient, what I want to just point out is this is a big study, but these are key points I picked out when I was reading the study. Can you believe that? Well, I can. 86.9%, so nearly 90% of patients living with HS, it significantly negatively impacts their relationships and sex life. 81.8% day-to-day activities, and social life, more than 83%. It's massive. I don't think we can emphasize it enough, that the massive impact. And of course, living with it, pain, 97% of patients list pain as the most difficult aspect. So again, Alison talked about, you know, working together, that integrated working, and we must work alongside our pain specialists, our pain clinics, and involve them to support our patients. So I want alarm bells to start ringing for you, and I'm sure they already do. But in practice now, moving forward, you know, I want to start asking the questions. You know, if you've seen a patient, ask about, you know, have they experienced any outbreak of these boils? Because I guarantee you'll be asked to be seeing them because they've got what they call boils or abscesses. So not just asking them, look in their previous history, look back and see if there is either a family trait, or if they have had repeated episodes of boils or abscesses, particularly in the areas that Alison's mentioned. So I'm not going to go through all of those. If there are multiple boils or abscesses, are they located in more than one area? Okay. If you're answering yes, or the patient's answering, or you found the answers in the patient's history as well to those questions, please don't wait. Okay, think that this may be HS. This has to be diagnosed. I'd rather have a diagnosis that isn't HS, but I will refer my patients to get that diagnosis. You know, so what I'm trying to say there is, please, if you're unsure, please don't wait. Still widen that MDT team and ask that question, could this be HS? And I've had various patients who I've helped to support with HS, because as Alison says, there's no cure. It's the best treatment, the best support. You know, it's supporting them through all of that. It's giving them tips, solutions, and ongoing mental health support. But when I had a patient, and I'm going to share it, I feel passionate about, we have to share true stories. And the patient one of the first young patients I saw was 18, and he presented at one of our tissue viability clinics and was referred due to recurrent abscesses under his arm and in his groin. He'd had multiple surgical interventions to remove sweat glands from under his armpits. He'd had various interventions for surgical drainage of the abscesses, absolutely resulting in significant scarring as well. He'd had recurrent abscess formation. It hadn't improved it to any degree. And I got to know this young gentleman very well because he was suffering really considerably with mental health issues around this condition. He'd started at university, he was a keen rugby player, fantastic rugby player. He'd only been 6 months in starting at uni and just turned 19, and he gave up his course. And he gave up his course because he couldn't live with these wounds. He couldn't live in dorms or accommodation and having to try to discreetly change his dressings or hide the smell. He couldn't play rugby, it was too painful. So as a consequence, he put on a lot of weight. He was then bothered about his body image again because he couldn't play his favourite sport. So he thought, there's no point in this. He was doing well at his university studies, but he left. And when I was talking to him, he'd had this condition or the abscess formations for 3 years. Now that doesn't sound a lot, but it's enormous. And nobody had diagnosed him with HS. Nobody had referred him on other than to tissue viability to say, how can we help to dress the wounds? So I'm talking a little bit there, but it was important we got the balance right for this young man. He talked to me about suicide. And I had to, I did refer him and with his consent, and he had some mental health support, some counselling. And I was very worried about this young man. So he was referred to dermatology. We referred to the wider team. The team were very much involved with his wound management. But a new solution came about. And I was really excited because it was difficult to dress his wounds. And he didn't want to see the practice nurse every day. He didn't want his mum doing his dressings, because that was another suggestion. Maybe your mum could dress your own wounds. No, thank you. I don't want my mum dressing my wounds, embarrassment and everything else. I started to look at what was available. And one of the solutions was this wearable wound care system called Hidradenitis. And you can see a picture of that on your screen. And I was thinking, oh, this looks, I like anything new anyway, but I thought this has got to be helpful. This has got to work for patients who are having to change these dressings and who are reliant upon clinicians and don't have to be. So as I've just said, it's a wound care system. It's a system. It's a garment, a soft garment that is worn. So there's various garments. There's the crop tops, and again, we'll refer to some information for you at the end of this. So the garment's worn, and then you've got the non-adherent dressings, so the absorbent dressings that are going to lock away that exudate, minimize and reduce the microorganisms within that wound area and help to reduce infection. So where Alison was saying it's not caused by infection but can lead to infections, but it's non-adherent. So we're not going to get that skin stripping. We're not going to get that surrounding skin adhesive damage, and it's held in place with very clever customized loops and fastenings. And traditional dressings, where normally because of the contouring, because of the body movement, they can often pinch, can't they, or bunch up and certainly move off. This is so flexible that it can move, it can contour, and it can sit nicely against the patient's skin. I'm going to show you a video in a minute. So I've talked about some of the benefits, but it is the first wearable wound care system. And we're talking about HS here, but I want you to think wider at the end of this, because I have now started to use this system for some of my patients with those difficult wounds. And it's dramatically, absolutely increased the patient's ability to be involved in supported self-care as well. So it's straightforward, safe, removes that risk, as I've said. It has been clinically proven, so I'm going to share some of the studies with you, to improve the patient's quality of life using that quality index score system I was talking to you about. So again, it's going to prevent that leakage, that embarrassment, quick dressing changes. And I'm talking far too much. I'm sure you'd rather see the video, so I'm going to play the video for you, how quick, in just 30 seconds, that dressing change can take place. Hopefully the video's playing. So that took 30 seconds. Okay. Now, okay, the patient might have more than one wound, but I saw a patient recently who was having a community nursing visit to do a daily dressing that took 40 minutes. Due to multiple dressings, yes, but the dressings didn't remain in place for the whole of that 24-hour period. So in between, he was sandwiching up the dressings with others. But you can see how fantastic, how the patients can become independent, change the dressing as and when they require very quickly. And as we can see, there's various studies done around the quality of life, and one done by Maloney et al. Showed that 100% of the patients with HS that they studied reported improved quality of life by using the HydraWear garments. It just gave them so much more independence. We also need, of course, to make that available to the patients. So you as clinicians, we should be making sure that the patients have the appropriate garments and dressings available to them. Why wouldn't you? You know, why should we? And it's not, you know, it's for their life. Yes, it is, we talk about, but it's going to make significant cost savings as well. Cost savings to your time, cost savings to the health economy, but also for me, the biggest is the savings to the patient. We've got to ensure, you can as clinicians ensure that integrated working with that patient, you know, referring to specialist services, referring to pain clinics, to dermatology, to the GP, all of those factors. If the patient has an issue with obesity or smoking, we can refer them for support to help them with that. Other advice we can be giving our patients, because that's what we're there for, to support them, is looking at avoiding shaving, you know, avoiding any further trauma to those wound areas, wearing natural loose clothing, again, to prevent any aggravation or irritation, and avoiding, you know, highly perfumed products. Use pH balanced wash products, because again, they can keep the acid mantle of the skin healthy and try and prevent any irritation or aggravation. So some little advice there as well. But it's important that we offer that patients living with this condition receive that ongoing support. You may see the patients for a short period, and fantastically, let's be confident and positive. These patients' wounds go on to heal, and they go on to heal really well, but they will still require that ongoing support and management because the condition is not curable. So lots of support groups you refer your patients to. These may be face-to-face, there will be some online platforms, because some patients participants might not want face-to-face, but there's the British Skin Foundation. I'm not going to go through them all. Your Hidradenitis Suppurativa online. Please give these links. You know, don't forget also the mental health support links and anything else that is going to support not just your patient, their families in managing this long-term condition. The British Dermatological Nursing Group, they've put together a multi-professional consensus statement you can see on your screen, and that's for the assessment, diagnosis and treatment of HS. Alison was a member of that group who represented the tissue viability. And there's a good section again on improving wound care management. There's a wound care pathway and a guidance framework for those wound care selection solutions. So I would refer you to download that. And then also alongside that, Alison worked alongside Suzanne on a wound and skincare support booklet for HS. And we're going to put those links up to those documents on the screen at the end of the session. And you can see an example of that clear patient pathway that Alison was involved in producing in that document. And by having a clear patient pathway for patients affected by HS, we are better equipped then to ensure that in timely diagnosis, better equipped to provide ongoing support and improve the outcomes for those living with this chronic debilitating condition. And so finally, yeah, HS is a devastating condition, but it is a condition that we can manage so effectively, okay, so effectively with the right timely diagnosis and the right advice. Faster diagnosis, will prevent progression of the disease and progression of significant complications of the disease, such as scarring. This will have a dramatic impact on the patient's quality of life, and I'm sure our stories have already shared that with you, but also reduce that economical burden to wound care. And you, all of us, can make a difference by being aware of the disease now. Be aware of it. Look for those early clinical signs. Spread the word to your colleagues, Ask those questions. Think of the alarm bells that I talked to you about. Ensure patients with HS as well, most importantly, have that appropriate wound care systems and products and advice. And I hope that Alison and I have supported you tonight in recognising this condition, understanding its devastating impact to the patient, but giving you the advice and support of how you can recognise and manage the patient. So I'm going to finally end before the questions and answers with Ed, and I'm going to have a little bit of a call to action. I think we all must raise awareness of HS, not just amongst healthcare professionals, but I think to the general public. So I think it's all of our responsibility to do that. We need to ensure that timely access to treatment and support and prevent, that horrible progression of the disease. So my call to action to you is to share your learning this evening, to direct your colleagues and just people, patients, members of the public, direct them to what this condition is. There are references which will be available to you. I'm sure you don't want me to go through all of those. I'm sure you're keen now that we hand over to Ed and start our question and answer session. Thank you.
Great. Thank you, Alison. Thank you. And ladies and gentlemen, there's so many comments, so many questions. Guys, do you mind if I crack on? So we're running out of time.
Oh, crack on.
6 have been sent through immediately. But genuinely, everyone, thank you so much for your interaction and the comments. So what I'll do, Ali, why don't I start with you? I'll alternate between you, but please feel free to cut in on the other one or add anything you want to, okay? So Ali, I'll start with you. Do you think we need to change practice on how we currently manage wounds in difficult to dress areas like the axilla, like the groin, like the buttocks?
Yes, I think we do, because we spent too many years wrapping people in adhesives around things and we're causing marzi. We know about all these things. We've got the evidence. So in a nutshell, yes, we do. We've got a solution. Let's use it.
Thank you. Joy, do you want to write anything there? I think that's
Yeah, I think, to be honest, I never got my Blue Peter badge, so I'm not very good at looking at something and adapting it. Never have been, never will. And joking apart, I think, are we not then if we start cutting dressings or changing the format of the dressing, are we then going to change the mode of action? So straight away then, it's not the dressing's fault that it's not working. We could be changing the mode of action. So we need more easier solutions. And we've said we haven't got the time to sometimes I have seen dressings being adapted that can take up to 40 minutes to be made before they're actually applied to the patient. So yeah, I think it's yes, we've talked a lot about HS, the condition, which was so important. That's what we were doing tonight. But I think it opens up that bigger arena now about the complications with some of these wounds.
Thank you.
In some of the areas. So
Joy, carrying on with you, how does the dressing help in the healing of lesions?
Well, okay, you've got me started now. So it's not just the dressing, it's the whole solution, isn't it? It's the garment as well. So if a patient can change the dressing, say there's high levels of exudate, Ed, and that patient can change that primary dressing to that area more frequently, very easily, without complications, guess what we're going to do? We're going to lock away that exudate. We're going to make sure that exudate doesn't have those harmful enzymes released that are going to delay wound healing by destroying protein. Straight away, that's going to help wound healing. If we can lock away that exudate or change it more frequently, the microorganism burden will be reduced, so it can help to reduce the risk of infection. Hey ho, we're going to heal the wound more quickly. So, and the whole point around supportive self-care, and there's lots of references to supportive self-care, the solution helps that in the sense of the patients taking ownership of not just their wound, their condition, which has been shown through studies to help wound healing. Absolutely, it helps patients' wounds to heal more quickly. because they are taking that ownership and being involved in it. So I could talk at length about why it would improve wound healing, but some of the scientific facts and some of the more facts about the supportive self-care as well.
Brilliant, thank you. So Ali, over to you. Question 3. Is it more common in females than males?
It is, and I'm sorry, I should have mentioned that, and I didn't quite get that point across. But yes, it is about 3 times more common in females than males. Obviously, I've talked about the hormonal factors, but that isn't to say it doesn't affect males. I've seen many males with it. Joy talked about the guy with who played the rugby at university, and maybe just with better data, we might get more, you know, of a balance. But that's where we are at the moment.
Brilliant. Joy, question 4. Sorry, Joy, go back to the last one.
I was just going to say, I meant to say about the young man is when we did put in the right solution, and he did have the hydro, the boxes and everything, and he could self-manage. What I wanted to say on a very, very positive note, 12 months later, he went back to his studies, went back to university, is back playing rugby, and it's just amazing. So I just want to say it does make a difference. And sorry, Ed, I think you have another question for me.
No, listen, that's good to hear, because that story broke my heart, actually. And ultimately, that's why we do what we do, isn't it? To try and improve their lives. So I'm glad there was a happy ending. So question for you, Joy. Why does it take so long for a diagnosis?
I think because it's frequently almost 90% misdiagnosed. It's acne. This young boy was told at first, even though it was under his arms, because it could sometimes as Alison said, different sites could be the back or the breast, told he had acne. He'd had multiple courses of antibiotics for acne. He'd had various washes given to him to wash in this, bathe in that, scrub with that. I think it's the misdiagnosis, Ed. And also because it's one of those conditions, and I don't know if you agree, Alison, when you do see it at first, even as a clinician, it does look like abscesses, and it does look like boils, and it does look like, and very frequently I can understand when people go, oh, it's just an abscess or it's just a boil. But I think it's the pattern of the reoccurrence, I think, and the location that alarm bells should ring. But it takes so long because it's not diagnosed. People are just saying it's misdiagnosed, basically, for various other conditions, and then there's another delay in referral, and another year and another year and another year, and because the patient might have an episode where they don't have a recurrence, the GP thinks, oh, it's just another flare up of the abscesses. I've seen so many patients go to surgery for drainage and excision of these abscesses like 4 or 5 times a year in hospital, having them drain and excise, and still no diagnosis. Because on the right treatment and with the right, Alison said, we aren't talking about the other treatments, but with the right combined treatment and management, honestly, they're so successfully treated.
And that's why we've got to raise the awareness, because GPs who have a special interest in dermatology will recognise it. Obviously, nobody can recognise everything, but this is why we're doing all this work, and that's increasing. And
just ask those 2 simple questions, really, and look back in the patient's history. If they can't remember, look back in their records. Don't just rely on them telling you that they've only had one episode, and just let the alarm bells ring sometimes. And if it's not HS, doesn't matter. We've asked about this, why they've got recurring wounds in this area. So if it isn't HS, let's find out what it is then, or what is leading to it. So, that referral is for all reasons, not just to diagnose the HS.
Brilliant, guys. Thank you. So I'm aware that we've kept you guys for just an hour now. So we've got 2 more questions and then we'll wrap up. Fine. So second to last question. Why are HS patients commonly prescribed antibiotics long-term as a way of managing their wounds? Is this an appropriate choice?
So antibiotic therapy is used with patients in their treatment with HS, but it's not the case of like cellulitis, flucloxacillin, QDS for 2 weeks, like we usually do with kind of skin infections, wound infections. it might be, it's different antibiotics. I won't go into them all right now of but that's often then that treatment plan will be put into place in dermatology. Somebody presenting initially to a GP will probably be given, you know, the usual suspects of antibiotics, but they might not be very effective, and they might have prophylactic type of antibiotics through dermatology along with other treatments which are biologics. Again, that's another webinar in itself, you know, but so that's why, you know, and antimicrobial stewardship, resistance, we have to be aware of that. So they have to be having the appropriate treatment by the consultants who know what works and have that plan in place.
Brilliant, thank you. So Joy.
But as clinicians, we can be doing lots of the other work alongside their wound management, the signs and symptoms, you know, their quality of life issues, all of those other factors as well. And like you say, sometimes the antibiotic therapies are sort of prophylactic, but I think a lot of, I still feel passionate that if we manage the wound more effectively, a lot of those infections would be reduced. I'm not saying they wouldn't need antibiotics at some point, but I think a lot would be reduced. I think a lot of the antibiotic use is due to, yeah, we're not managing the wound signs and symptoms as effectively as we could.
Brilliant, thank you. So last question. We have a patient with HS. Can we get Hydraware prescribed for them?
You go, Alison.
Yeah, it's on drug tariff. It's there. It's don't get me started. It's on drug tariff. It's there. It's available to prescribe. We look, as TVNs, Joy and I know, and those of you in the audience, we know about formularies and how that works and products on formularies. If you are a TVN listening right now, this needs to be on your formulary. Put it on there. This is for a specific purpose. People, and I talked about inequalities in care, the NHS long-term plan and all that. This works for people with HS. They deserve to have this. It ticks all the boxes, the net zero, sustainability, it's cost effective, it works for them. So, you know, we have to also empower our patients with the advice and knowledge to go to their primary care networks to say, look, this is the solution for me. The NHS long-term plan is saying this, so why are you not giving me the treatment that I need and deserve?
And I think just to add on to that, Alison, I know that Cheryl Handley's just wrote a really good article on HS diagnosis and treatment, and I would recommend that. And within that, she's actually broken down cost, and she broke down the cost of a patient being managed daily with 2 foam dressings, etc., plus the DN time. And it was per month, it was just short of £2,000. When they swapped over to using the Hydraware and the dressings and the patient doing the dressings, oh, it was like not even a third of that cost. So if you have to fight or argue with your primary care networks or wherever, that to me, just show them that, you know, if they're talking financial or health economics, just show them evidence of that. To me, you shouldn't have to, because it's about the patient. But just show them it's massive cost savings, but to me, massive savings for the patients as well.
Guys, thank you. Love the passion. I know how much work's gone into this, not just over the last hour, but over the last few weeks, months. So a massive thank you from me. A massive thank you to all of you guys for your comments, your questions, and for the numbers you've joined us in. It's quite humbling for me and the team. The link for your certificate of attendance is available now. So as I said, download that, because that counts towards your revalidation. Just a few thank yous. Alison, Joy, it was outstanding. Really important session, I think. And I'm sure this will be seen by thousands in the coming days. So a massive thank you from me. To the Wound Care Today team, to the Mold Digital team, you guys are amazing as always, and make this look very professional. And I'm well aware of the work that goes on behind the scenes. And you know, you don't need to support these kind of events, but you have. So a massive thank you again from me. And finally to you guys, you continue to inspire me, the speakers and the team. Stay safe, stay strong. We'll see you very soon. Have a lovely evening. Thank you very much. Good night.
Thank you.